Anvisha?
Pilocytic astrocytoma will be the
Yes.
WHO grade 1.
Yeah, CNS WHO grade 1. So the whole diagnosis would be pilocytic astrocytoma, CNS WHO grade 1. Good, very good. So with that, we finished the first case. I can see Anamika heaving a sigh of relief. Thank you, you did well. So we go on to the second case. This is going to Anvisha. All right. So Anvisha, you said that you have seen very few brain tumors in the past. So let's see whether you can at least broadly get some idea on this case. Okay. So can you see the screen?
Yes, ma'am.
Please read it.
15 years male patient with generalized tonic-clonic seizure for the past 9 years.
Okay. So Kajri, shall I just
Whatever, ma'am, I'll describe
Like,
this.
yes,
So basically, we are seeing two images. The one on the left side is an axial T2 weighted image, and we can see the pathology which is marked with a red arrow. The one on the right side is a post-contrast T1 weighted image. How do we identify? Again, I told in T1, gray is gray and white is white. So basically, in the T2 weighted image, what we see is there is a lesion in the medial temporal lobe, medial and the anterior part of the temporal lobe on the left side, which is a little bit heterogeneous. It's not well defined, so I'd say it's a diffuse type of lesion. And in the post-contrast imaging, what we can see is there is no obvious post-contrast enhancement. So this much we can see.
Okay. So Anvisha?
Here we see a HNE stem section showing diffusely infiltrating a neoplastic oligodendrocyte.
At this power, what can you really can't see that the oligodendrocytes.
Moderate cellularity.
Yeah, I would say mild, very mild increase in cellularity. Okay, moderate would be much more. You're seeing more of this pink background, and it's actually it's the cerebral cortex with the tumor just going into it. So you're seeing just a mild increase in cellularity, but here it's moderate. I agree. Yeah, describe this.
Here we see round to oval cell with round nucleus with perinuclear halo in a eosinophilic glial stromal glial background with delicately thin blood vessels.
Okay, the pericardial halos you're seeing more at high power, right? Over here.
I mean some like.
Sorry.
Oh,
yeah, and these here are some entrapped neurons. So this is another high power view. Sorry, someone's again asking to annotate. I just take my pointer.
I'm sorry, Dr. Geeta, this is
perineural microcalcification.
Sorry, 1 second, Anvisha. So here you are seeing the tumor cells that you described, and these here are neurons, okay, which are normally in the cortex. Can you see some cells are present here as well? What is this phenomenon called, do you know?
Perineural satellitis.
Yeah, perineuronal satellitis is good. And here you're seeing
microcalcification.
Lots of calcification. I provided this OLIG2, which you learned in the previous session, is a transcription factor. And what are you seeing here? It's positive?
Cells are positive for OLIG2.
Okay. And ATRX?
ATRX also positive.
Yeah, so ATRX is interpreted as either retained expression or loss of expression. So here you would say it is retained expression. So now, how is your mind working on this case? What would you like to do next?
I'd say IDH.
You want to do IDH. Okay. This at this point, we have a 15-year-old with a how many year history of seizures? 9-year history. So that means from the age of 6, this child has had seizures, right? So it's fairly long standing. And you said you saw a oligo-like morphology, and you want to do an IDH because you're thinking of a
oligodendron.
Yeah, but an oligodendroglioma generally would not have such a long standing history. Okay, it would be a shorter history duration of symptoms. So here actually that's why with that age group and with the long duration, one has to think of those low-grade tumors that occur with epilepsy. All right. So you wanted to do an IDH. I'll tell you that the IDH is negative. So this is the crucial factor here, 9-year history of seizures. And these are some more images to show you the surface of the brain and just a mild increase in cellularity. It's diffuse, it's going into the cortex. Here, a little bit more moderate cellularity. Like you rightly pointed out, there are these thin-walled vascular channels and a very oligo-like appearance in monomorphic cells, monomorphic nuclei, diffusely dispersed with some clearing of the perinuclear zone, very much like what you expect to see in an oligo-like tumor. So you have OLIG2 positive. Therefore, what does that imply? That it is likely to be a glial tumor, correct? Anvisha?
Yes, ma'am.
Yes. Now, ATRX is retained, but IDH is negative. So now, do you think you want to do something else?
If we show 1p19q co-deletion.
Okay, so you're still thinking of an oligodendroglioma, and you actually ideally then should be doing a PCR for IDH to look for the mutation and a 1p19q for oligo. But we're not going there because that's an adult type diffuse glioma, which was dealt with in the last session. We're looking at pediatric type tumors. So do you think there are other? Remember this very morphology of cells. That particular morphology, an oligo-like cell, may be seen in many other tumors. It need not be an oligodendroglioma alone. Okay, you can see an oligo-like appearance in neurocytomas, which are tumors of the ventricle. You can see an oligo-like appearance even in other tumors like in ependymomas or diffuse glioneuronal tumors, DNETs, the centroplastic neuroepithelial tumors. All these can have oligo-like appearance. So this particular tumor, I think it may be difficult for you to come to. Here, this particular marker that we've done, given the history and given the oligo-like appearance, we did a CD34, and CD34 is showing positivity both within the tumor and in the adjoining nervous tissue. Now, does this give you an idea, or shall I just proceed? don't worry about it. It's a newly described entity. It's, we ourselves are becoming more aware of it only now. So it's perfectly all right that you have not thought of this tumor. But this one is what's called polymorphous low-grade neuroepithelial tumor of the young. And since it's a very long name, it's called plenty in short form. Right? Now, these tumors are grade 1 tumors. They are seen with a long-standing history of seizures in young individuals. They have a diffuse growth pattern. They have an oligodendroglioma-like appearance. They definitely show calcification, lots of it. And they are positive for CD34. So the clues are this long-standing epilepsy, young adult or young children, median age is 16 years, our patient was 15, usually in a cortical location. This is another case which I got from Dr. Vani, where you can see the tumor in the cortex. Here again, a diffuse growth pattern. And in her particular case, apart from this oligo-like appearance, there were other areas which had pleomorphic cells with and some spindle-shaped cells as well. So when you see a tumor like this, and you see a lot of calcification, there's no mitosis, there's a long-standing history of seizures, one has to think of this entity called plenty. It's a CD34 positivity in the tumor, and the adjoining area also shows CD34 positivity. The IDH negative, ATRX is retained. This is the cerebral cortex showing the CD34 positivity, and this is OLIG2 positive. Now, these tumors are BRAF V600E positive by immunohistochemistry and molecular testing. We did not do this. We did not do a BRAF in our particular case. They have low proliferation indices. So most frequent is the MAP kinase alteration of BRAF V600E. It could also have a FGFR fusion. And the good thing about it is that it's got a, if you remove the tumor, they have a good seizure-free outcome in these patients. So it's important because there's a big difference in prognosis between a tumor like this and an oligodendroglioma. So essential criteria for this in the WHO is a diffuse growth pattern, oligodendroglioma-like component, if at all, very few mitosis. The CD34 is characteristic in both in the tumor cells and in the adjoining cortex. IDH is wild type. It's an essential criterion that you have to prove that it's IDH wild type, which means if it's IHC negative, one needs to then do PCR. And there has to be expression of BRAF V600E either on immunohistochemistry or molecular evidence of a MAP kinase pathway alteration. All these are essential criteria. So without having all these, one cannot make a very definitive diagnosis. So now, going into looking at it as an integrated diagnosis, at a histological level, we can say it's a polymorphous low-grade neuroepithelial tumor. What grade did I say it would fall into? Anvesha?
Grade 2, ma'am.
It's a grade 1 tumor. Okay, but here the molecular information we did not do in this diagnosis in this. Someone else wants to volunteer?
Polymorph.
Grade 1 polymorphous low-grade neuroepithelial tumors of the young.
And yes, and then what will be your grading?
Grade 1.
Okay, would you say NOS or not?
We will say NOS.
Why?
Because it's not specified.
No,
We have not done the molecular.
Exactly. We have not done the molecular workup, which is essential criterion for diagnosis. And therefore, we have to call it a NOS. And in that situation, it does not become a CNS grade, but just a histological grade of 1. This is what Dr. Vani told you all at her session. And so this, I want to emphasize this. NOS comes in when you have not performed the molecular test that is essential for making the diagnosis. NEC or not elsewhere classified comes in when you have done the molecular test, but they do not fit in with what is typically described. So in this situation, you use NOS for this particular tumor. So a little bit about pediatric type gliomas. This comes under the diffuse group of tumors. Most often have MAP kinase pathway alterations, particularly in the low grade. This shows you that pediatric type tumors can occur in adults, and adult type tumors can occur in children. So there is no hard and fast, but the frequency is different. So you see less often you see adult type tumors in children, and less often you see pediatric type tumors in adults. So just let's focus only on the low grade. The 4 low grade tumors that are described are the diffuse astrocytoma, MYB or MYB1 altered, the angiocentric glioma, this plenty, and the diffuse low grade glioma, MAP kinase pathway altered. So why were they separated out? Because they have, in the past, I'm sure that I myself would have called these tumors oligodendrogliomas in a child. But now we know differently. And it is because they have different molecular characteristics, they have different clinical outcomes, and a lot more has been done to study these to know that they are a completely different tumor. So they have a much lower progression rate, and they do not show the alterations that are seen in, oh gosh, someone else wants annotation. Sorry, 1 second. Yeah, do not see the alterations that you see in adult tumors. And they have an indolent behavior. And compared to circumscribed gliomas, we said circumscribed gliomas are the pilocytic astrocytomas and so on. These have diffuse gliomas have a higher recurrence rate. So when you look at the prevalence of this, if you're again looking at these low-grade gliomas, the diffuse gliomas are not very frequent, but they are seen. This light blue sector shows you what the frequency of these low-grade diffuse gliomas are. It's different from circumscribed in that they're diffusely infiltrating into the parenchyma. And more than 50% of them occur in the hemispheres. And the rest occur in other parts of the brain, like the hypothalamus and the brainstem and so on. And this I've shown before in a previous talk. The diffuse, like I said, is that the tumor cells diffusely go into the brain parenchyma. So here you're seeing what is called subpile. This is the pia, subpile satellitosis. Anvesha talked about this perineuronal satellitosis. Yes, I think in the last class, Vani had shown perivascular satellitosis, and that's the tumor cells sticking to areas, to certain parts or congregating in those areas when they diffusely infiltrate. So these are the 4 pediatric type diffuse low-grade gliomas: plenty, angiocentric, the diffuse astrocytoma, MYB or MYB-L1 altered, and the MAP kinase pathway altered. So the angiocentric glioma is also a CNS grade 1 tumor. They have these bipolar cells. Angiocentric means they're located in a perivascular space, and most often they show this alteration of MYB to QKI fusion. Again, long-standing history of seizures occur in children and young adults. And here's a child who had focal motor seizures from the age of 2 years, just a 4-year-old child with a tumor in the temporal lobe and thalamic region. And here you can see the diffuse nature. These tumor cells are migrating all the way up to the surface, right up to the subpile region. You're seeing it mainly around vessels. And in this, along here, you can see this angiocentric pattern. Can you appreciate this very radial arrangement around vessels like a sleeve? Again here, and they are bipolar monomorphic cells, which are seen within the parenchyma. So here you don't see mitosis, you don't see microvascular proliferation and necrosis. It's around the vessel, so therefore the name angiocentric. And classically, they show dot-like positivity for epithelial membrane antigen. There's another tumor where you see dot-like positivity. Do you know which one that is? For EMA? We'll come to it later. So here you see this dot-like positive because it's a glial tumor, you get GFAP positive. These tumors are OLIG2 negative. Unlike the other tumor that is OLIG2 positive, these are OLIG2 negative. And they often show this MYB QKI gene fusion. So essential criterion here is, again, you don't need molecular, diffuse growth pattern with focal angiocentric and immunophenotypically evidence of astrocytic or ependymal differentiation. If this is present, you can make a definitive diagnosis based on the history. The diffuse astrocytoma MYB, MYB-L1 altered is also a CNS grade 1 tumor, again in drug-resistant epilepsy, again a diffuse low-grade glioma, very monomorphic diffuse pattern of infiltration of tumor cells. They have retained ATRX. They are another set of tumors that are OLIG2 negative. And this requires this demonstration of the MYB or MYB-L1 fusion to make a diagnosis. There is a surrogate marker with a protein available, which can be seen as a nuclear accumulation and important to diagnose because they have a good prognosis. So in this particular entity, amongst the diffuse gliomas, one definitely needs to prove that there is no IDH mutation, there is no H3 mutation, and there is an alteration in MYB or MYB-L1. So if one sees a low-grade glioma or astrocytic tumor in a child with a diffuse pattern, it doesn't fit to the other two, it's OLIG2 negative, one has to consider this, but without these, you just be at a NOS level with the diagnosis. And the last one, the MAP kinase altered, is again a tumor which has a diffuse pattern, could look like an astro or an oligodendroglioma, but you diagnose it only by the MAP kinase pathway alteration. So again, long-standing history of seizures, either an oligo or an astrocytic pattern. These are OLIG2 positive, and you have to demonstrate that they are wild type for IDH, wild type for H3, no deletions present for 1p19q, and they are MAP kinase pathway altered. So in this tumor, one definitely needs demonstration of these molecular changes and absence of CDKN2A deletions to make a diagnosis of this tumor. Otherwise, it remains a low-grade. If I have a low-grade tumor like this, if I'm not doing any of this, I would just say pediatric type diffuse low-grade glioma, NOS, and leave it at that, and refer it to a larger center if it is required to do, or if the patient can afford to have these other testing done. So if you look at pediatric type diffuse gliomas, the singular feature is that there's long-standing history of epilepsy, children and young adults, usually an insidious onset. The IDH wild type, H3 wild type. Two of them are OLIG2 negative. This is the angiocentric one, which has a very typical classic angiocentric pattern of tumor cells, and they are EMA dot-like positive. And the other, which requires demonstration of the MYB, MYB-L1 alteration. And then there are two that are OLIG2 positive. The one which we had is our case, could have an astro and oligo-like look, more often oligo-like look on morphology. Definitely shows calcification, is CD34 positive, and one can make a diagnosis. But by WHO criteria, if you don't do the molecular test, you have to stop at NOS. But you can give a more definite diagnosis of plenty. And the last one, again, you're required to demonstrate this feature. Important to know this because oligo-like appearance is seen in many of these, but they're IDH wild type, and therefore they're not oligodendrogliomas. Oligodendrogliomas almost always IDH mutant. Right? So going on to the next case, before I go on to the next case, Dr. Tejpal, I've discussed some low-grade tumors. Would you like to say something?
Yes, I think there were a couple of questions I saw in the chat box. Is the treatment any different for these pediatric low-grade gliomas? So I think the first line of treatment is surgery. Of course, in the midline location or supracellular location, radical surgery is not possible, but pilocytic in the cerebellum, pretty much gross total resection is feasible. So you do a maximal safe resection in these tumors, and if you achieve a gross total resection, actually no further adjuvant therapy is required. As far as the diffuse low-grade astrocytomas or the pilocytic astrocytomas, which are residual or recurrent, we definitely treat them. And the current mainstay of treatment in children is systemic chemotherapy using vincristine and carboplatin. That's one of the common regimens that is used. In the last few years, increasingly, since we know that they are RAS-MAP kinase pathway disease, inhibitors, the BRAF inhibitors and the MEK inhibitors are used. If you demonstrate a BRAF V600E mutation, then you use a combination of the BRAF inhibitor and the MEK inhibitor. And if there is a BRAF fusion positivity, then only a MEK inhibitor suffices. So in the last 5-7 years, I think there has been a change in the approach to managing these pediatric type circumscribed as well as diffuse tumors based on molecular alterations. One thing that I would just like to mention is that vast majority of these pediatric low-grade gliomas are actually RAS-MAP kinase pathway. So that is something that one needs to remember. Of course, all of them cannot be targeted by the BRAF inhibitors and MEK inhibitors. Some of them have FGFR alterations, some have some other alterations. But for the most part, a significant proportion of them can be treated successfully with BRAF inhibitors and MEK inhibitors. Of course, if you have excised them well, there is no significant residue, then you really don't need to treat them. And they have a very, very good prognosis. Most of these tumors have a very good prognosis.
Are there any other questions in the chat box?
No, ma'am.
So to summarize, here the main thing is identifying a low-grade tumor compared to a high-grade tumor. So all the features that make it low-grade in terms of cellularity and proliferation and so on. And then remembering that in a child, the diffuse gliomas, even if they have the morphology of an adult-type tumor, actually have are CNS grade 1 tumors. And they're entirely different entities which can be picked up, which can be diagnosed either with immuno or molecular testing. And it's important because it really makes a difference to the prognosis and the outlook for the patient to be able to identify these tumors. So if, shall I just go on to the next case?
Tejpal, do you have an opinion? Tejpal, do you like to comment? Yeah, so I just made some comments regarding the treatment which has evolved over the years. And previously, most of these children, say 20 years ago, actually used to get postoperative radiotherapy if there was a residual disease. Now, radiotherapy is no longer the frontline treatment after surgery. We would use either systemic chemotherapy or the targeted therapy with BRAF inhibitors and MEK inhibitors. We have to remember that these children, a significant proportion of these children get cured. And that's why we have to try and sort of reduce the late effects of our treatment.
Okay, thanks. So we'll go on to the next case, and this is with Burjir.
Yes, ma'am. Ma'am, we have case third, 16-year-old male, headache and vomiting for 1 month, and a blurring of vision and restricted eye movements on the left for 2 weeks.
So it's a short history, correct?
Yes, ma'am.
It's a short history.
Ma'am, should I describe?
Yes, please, Kajri.
So we have, this is what we call as a flare image. So I have not described it in my presentation, but this is exactly the same as T2. That means the gray is white and the white is gray, but here the fluid is suppressed. So this particular sequence often helps us to identify the edema, and the lesions are often better seen in this particular sequence. So here what we are seeing is there is a lesion. So this is your pons. The lesion is located in the posterior part of the pons, and it is a fairly well-defined lesion, I would say, and it is a little bit hyper-intense in flare, but the location is important. So the patient is presenting with headache and vomiting, and that is basically because the lesion is compressing upon the fourth ventricle. If you look at the sagittal, this is the sagittal T1 weighted image. So it's basically in the pons and medulla, as we can see, and it is compressing the fourth ventricle, and therefore it may occasionally be leading to features of raised intracranial tension, and that's why the headache and vomiting. And because it is located in the pons and it is affecting the cranial nerve nuclei, the patient is having visual symptoms. So that much we can say from this image.
Okay. Thank you. So it was a highly vascular tumor at surgery, and this is the smear preparation.
It's a hypercellular smear revealing sheets of cells without any particular arrangement, having fibrillary processes. And in the first image, the first question is there was focal necrosis on one side. We could see necrosis.
Okay.
Yes, ma'am. And then the higher image of this squash, individual cells are spindled with elongated hyperchromatic nuclei, with many thin vessels traversing through these cells.
Okay.
And in a fibrillary background.
Okay. I'll later on show you what thickened vessels look like. Here, although you're right that sometimes these tumors do have the vascular proliferation seen as thickened vessels. Here, we're really just seeing it as parallel rows of endothelial cells. So I wouldn't quite say these are thickened in the smear, but it's very cellular, like you rightly said, and it's quite pleomorphic in appearance, right? So this is the fragments that we got of the tumor.
In this histopathology section, we can see 5 tissue bits that appear cellular at this power, and few of the bits show hemorrhage.
Yes.
Diffuse hemorrhage.
Yes.
In this one, section 6 reveal hypercellular tumor. Tumor cells comprising of pleomorphic cells having high NC ratio, hyperchromatic nuclei with prominent nuclei and eosinophilic cytoplasm.
I think you're seeing too many prominent nuclei. There's one here, but yeah, okay. But yes, you're right. It's hyperchromatic. Yes.
And eosinophilic cytoplasmic processes blending with the surrounding dense fibrillary background, the matrix. And then there are a few mitotic figures in this, and along with some vessels and hemorrhage.
Yes. So I also gave you MIB.
I think the index is more than 60%.
Yeah, it's probably difficult to give a percentage with just an image, but you're definitely sure it's high, right, compared to when I showed you the parasitic. So now you have the short history, a tumor in the brainstem, and with this high-grade feature. So what would you like to do next?
I will go for IHC.
Okay.
My diagnosis, I think it's a diffuse midline glioma.
All right.
So I will do H3K27M.
Okay.
Then a GFAP for the glial cell to see it's a glial tumor. MIB we have already done. And P53.
P53. Did you say P53? Okay. See, GFAP, yes, you can do it, but again, like in the previous one of the cases that I was mentioning, if you're very clear on it being glial, you can avoid doing the marker. Okay. So I'll just show you a few more images. Here are some more images of the same case, showing this cellular tumor, like I'd shown you earlier with this pleomorphism. And this is what is more of the thickened vessels. Can you appreciate that? When you see vascular proliferation on a smear, it looks like this, like finger-like thick structures. Okay. Can you make out the difference between this and this? Here you're just thin. Here they're thick. Okay. And we had multiple fragments of tumor given to us. As you can see, they're very tiny, cellular, like you said, hypercellular, fibrillary background, a lot of pleomorphism, and mitotic activity. So you're right in saying that it's a high-grade tumor. It's in a child. It's diffuse. And so your highest on the cards is a diffuse midline glioma. So this was OLIC2 positive. All right. And so now next, you want to do an H3K27M. And how do you interpret this?
It is positive.
Showing diffuse positivity in the nuclei for H3K27M. Is there any other marker you can do?
We can do, if we have to differentiate it from oligo, because there are some oligo-like cells in it. So we can do IDH.
Actually, this is a very specific marker that tells you that it is got H3K27 mutation. So now you really don't need to prove anything else. But there's one more marker that you need to do to make a confirmatory. What broad group does this come under now? Or what is the full term for this tumor? Diffuse midline glioma. Then H3 what?
H3K27M.
That was the term that was used in 2016. There's someone who's mentioned here in the chat box, H3 altered. Now, for altered tumors, basically, they show a loss of expression of a trimethylation protein. H3 trimethylation protein, loss of expression must also be seen. And here you can see the internal control is positive. So in the new classification, it's called a diffuse midline glioma, H3K27 altered. And I'll tell you why that is said now other than mutant. And it's a grade 4 tumor. So these come under the group of pediatric type diffuse high-grade gliomas. We just finished with low-grade. And again, here there are 4 entities. And this particular one you saw came under the H3K27 altered. Now, you will see a loss of expression of the trimethylation protein. And it can either have the K27 mutation, or it can have an aberrant expression of a protein called EZIP, or if it's a bithalamic tumor, it can show EGFR mutation. So under the umbrella of altered, common factors, they all show this trimethylation loss, the H3 trimethylation loss. 2 of these will show the K27 mutation. This one shows EZIP overexpression, and this particular tumor is EGFR mutant, and this usually occurs in those who show tumors in both thalami. Both thalamuses are involved. Now in 2016, you're right, it was called the diffuse midline H3K27 mutant tumor. In the past, these were what we called intrinsic pontine gliomas. And but apart from the mutation in K27, what has been found is that this K27M and this other protein EZIP, they inhibit this polychrome repressor complex, and this is what mediates the trimethylation of H3. So when it inhibits it, there is loss of trimethylation activity, and so you see a global reduction in the trimethylation protein. So when there's EZIP overexpression, it will inhibit the PRC2, and therefore inhibit the methylation activity, and then you see reduction in the methylation protein. So what was found was when they studied midline gliomas, there was a certain percentage that were K27 mutant, but there were also those that were wild type. And when they did methylation profiling, they found that these were those that had ESIP overexpression, and therefore they got included in the same group. Now, so all those which have this trimethylation loss are grade 4 tumors. They have a poor outcome. They occur predominantly in the pediatric age group, and they may have other alterations also along with apart from the H3 K27 alteration. Now, how do you interpret this? If it is a tumor like ours, which has showing the H3 mutation and trimethylation loss, it is a H3 altered tumor, but basically it has this mutation. There are those that don't have the mutation, have the trimethylation loss, but show ESIP overexpression, and those are also H3 altered tumors. All right. Now, here's an example of a tumor which is high grade with a lot of bizarre forms. H3 K27 mutation is immunonegative. This highly specific marker for mutation, but there is a trimethylation loss. Right. So this would, and there is ESIP overexpression in this case. Right. ESIP protein is positive. So this is a diffuse midline H3 K27 altered tumor. Okay. Now, they also found that in tumors that occur in both thalami like this, when they did a genomic analysis, they found that they had EGFR alterations, either an inframe insertion in exon 20 or a mutation at exon 7. And these also had the trimethylation loss. So why was it important to identify these group of EGFR mutant tumors? It was found that these particular tumors, when they're given the EGFR or MET inhibitors, they have a far better prognosis compared to those that are not treated. So when you encounter a bithalamic midline gliomas are those that occur in the brainstem and all the midline structures, but also in the basal ganglia. So in thalamic. So when you see a tumor like that, particularly in children, which is high grade, you have to think of these diffuse midline gliomas. Do the H3 K27 and H3 trimethylation protein to diagnose it. If they're not K27 mutant, but show the loss of trimethylation, ESIP works for ESIP overexpressed tumors. And if it's bithalamic, often they have EGFR mutations. So they generally occur in the pediatric age group. They can occur in the brainstem, thalamus, occurs in children and adolescents, spinal cord, astrocytic tumors, astrocytic morphology tumors. You have to think of this particular entity, and you can diagnose it using the markers that you just mentioned. So here's a high-grade tumor with an astrocytic morphology. Here, a very hypercellular pleomorphism. You may or may not see vascular proliferation and necrosis. It's got retained expression of ATRX. It's OLIC2 positive. H3 K27 is mutant, and there's loss of expression of the trimethylation protein. So 50% of these tumors are P53 positive, and there are a few that show loss of expression of ATRX. But based on the location and based on these two markers, one makes that diagnosis. Someone says unable to see slides. Is that true?
No, ma'am, it is visible. I think it was the connectivity error from there.
Okay. So if one does Sanger sequencing, you can see that methionine replaces lysine at codon 27 of the H3F3A gene. And in the EGFR mutant tumors, you can either see a missense substitution in exon 7 or an inframe insertion at exon 20. So prognosis is important to diagnose because they have a poor prognosis. Though amongst these three, the one with the best prognosis is the one which has ESIP overexpression. And if you're less than 3 years or more than 10 years, you have a longer survival. And tumors that have EGFR mutation with targeted therapy have a better survival. So essential criterion, it's a diffuse glioma. All of them show loss of trimethylation protein, they're midline in location. And in addition, either you should demonstrate the K27 mutation or the EGFR mutation or the ESIP expression or do the methylation profiling to match with the diffuse midline glioma. So in this particular case, Burjesh, histopathological classification, it falls into, it has an astrocytic morphology, right?
Yes, ma'am.
It's an astrocytic tumor. CNS grade is?
Grade 4.
4. Molecular information, what do you have?
H3K27 altered.
Yeah, it has both the mutation and the loss of expression. We've done it by immunohistochemistry. So what would be your integrated diagnosis? Diffuse?
Diffuse midline glioma, H3K27 altered.
Yes.
Grade 4, WHO grade 4.
WHO grade, CNS, WHO grade 4. Because these markers have, you've got all the criteria fulfilled for this tumor. So that's about the midline gliomas. I'll quickly run through the others because in Dr. Vani's session, she said I would cover this. So I'll just quickly tell you about the other high-grade diffuse gliomas. Before that, Tejpal, you want to say something or shall I finish this and then you'll speak?
Maybe we could just finish, then I can.
Okay. So then you have, apart from those that occur in the midline, you have those that occur in the hemispheres. And amongst this one is the H3 G34 mutant tumor. This is also a grade 4 tumor. And it results from substitutions of histone with the G34V, alterations at the in the histone at G34. So it occurs in adolescents, young adults, and cerebral hemispheric involvement. You can see a GBM-like appearance. That means a high-grade appearance, a primitive appearance, mitotic activity, proliferation, necrosis. You'll be thinking of a glioblastoma or a primitive neuroectodermal tumor, but these are IDH wild-type tumors. They can show loss of expression of ATRX and overexpression of P53. But the one feature that they have is Dr. Vani also mentioned this, the lack of OLIC2 expression. So normally, when you see a high-grade tumor, you're thinking of a high-grade tumor like a glioblastoma, astrocytoma grade 3, or even in this, if it's a neuroectodermal-looking tumor, but they will have loss of expression of ATRX, which suggests that it's a glial tumor. They have overexpression of P53, again, pointing to this astrocytic morphology, but they have absence of OLIC2. When these three are seen together, one has to think of this entity. Ideally, by sequencing, you demonstrate the replacement of arginine with valine, but otherwise, there is a specific immunohistochemical marker available for H3B34 protein. So here's an 18-year-old child with generalized tonic-clonic single episode, so short history, and a hyperintense lesion seen in the posterior central gyrus, and there's some enhancement of